Welcome back to Africa Science Focus, the weekly science and development show from SciDevNet. I'm Ogechi Ekeanyao. We are back for our Science Explained series, and this week we're exploring access to sexual and reproductive health services for women and girls. Access to sexual and reproductive health services is a human right, but millions of women and girls in Sub-Saharan Africa have limited access to this life-saving service, making it a major public health problem. According to the United Nations Population Fund, only 54% of women in the region have access to essential antenatal care services. Only 29% of women in this region use modern methods of contraception, and only 52% of women in the region have access to safe abortion services. Consequently, the region has the highest maternal mortality rate in the world, with 545 deaths for every 100,000 live births, according to the United Nations Children Agency, UNICEF. In this episode, we examine the challenges that women and girls encounter in accessing sexual and reproductive health services, the implications of these challenges, and why these challenges exist. Our reporter, Michael Kaloki, spoke to Dr. Magda Robalo, President and co-founder of the Institute for Global Health and Development, who highlights the societal expectations of women and girls that restrict their access to life-saving sexual and reproductive care.
This is due to several factors. One of the most critical is the gender norms that create barriers for young girls and women to access health services. As you know, our societies have several customary norms that consider young girls, the girl child, young girls and women as a sort of second-class citizens who would only have access after men, after boys, after those who are considered most important elements of the society have been served. This is in relation to health, but it's also in relation to school. It's in relation to many other resources that society has to distribute to its citizens. Women, girls, young girls, and women are left behind when it comes to access to the resources that society has, because women are considered the ones who should stay at home to take care of the work for the family. Women are the ones who provide care to sick elements of the family. Therefore, they don't have time. They are not needed in schools. Women are the ones who need to cook, who need to go fetch water and cater for the needs of the family. But women are also considered as tradable objects. Women are exchanged between families for marriage, for example. We have a very high proportion of young girls who, from the day they are born, they are traded to older men who later in life will become their husbands. And we are fighting against early marriage of young girls. Therefore, they don't go to school, they have children very early, and their life is compromised. All this because of the social norms, the stereotypes that society for centuries have established around what a woman can be and what a woman can do.
Inadequate sexual and reproductive health care puts the health of girls and women at risk. This poor access can be fueled by deeply held traditional beliefs and norms that seek to police women's sexuality. For example, conservative views often tie a woman's worth to her ability to have children, particularly having sons. Getting married young and having babies without adequate spacing can have devastating consequences on women's health and can even cause their deaths. Dr. Tlaleng Mofokeng is the United Nations Special Rapporteur on the right to health. She spoke to Michael about the repercussions of societal limitations on women and girls' health, alongside the consequences of poor access to their reproductive needs.
If you look at the rate and the leading causes of death for women and girls between the ages of 15 up to, let's say, 20, 21, 25 years, it's usually complications from pregnancy and childbirth, especially in the developing countries, and when you do this with a global analysis, you will see that around 80% of maternal deaths are due to obstetric complications, mainly around uncontrollable bleeding during and after giving birth, so your postpartum hemorrhage, issues related to sepsis, which speak to infection, issues around unsafe abortion procedures, because in many countries, access to safe abortion is still criminalized or illegal and made even more inaccessible. You have conditions, of course, like hypertensive and diabetes disorders of pregnancy, for like preeclampsia and eclampsia, for example, or prolonged or obstructed labor. And when you're thinking about prolonged or obstructed labor, you require immediate intervention. That would mean that there's proper monitoring, there's proper timeous response, and that there are medical commodities and medicines required to be able to intervene. And in many developing countries, including on the Africa continent, just the issue alone of prolonged and obstructed labor leads to a lot of not just death, but also disability and morbidity for women and girls after they've given birth. And so on the one hand, we are counting mortality, but I think we also need to start counting the quality of life and the kinds of disabilities that people are experiencing as a result of pregnancy and pregnancy-related childbirth. We know that sexual and reproductive health rights and the services that are required for people to realize those rights are extremely important, and they are an integral element of the right of everyone to the highest attainable standard of physical and mental health. And yet we know that these many obstacles stand between individuals and their enjoyment of health, and they are interrelated, they are entrenched, and they operate at different levels. And some people realize really tough obstacles in getting clinical care. Some obstacles lie at the level of health systems and health governance and resourcing and leadership. And of course, some lie in the underlying determinants of health, such as infrastructure, roads, access to water, nutrition, and safe and healthy environments. And so it's important to really talk about maternal mortality rate, the health outcomes related to pregnancy and pregnancy-related conditions and healthcare needs as human rights issues, because they speak directly to the rights of dignity, of bodily integrity, of autonomy, of non-discrimination, and equality as well.
The provision of sexual and reproductive health care is a responsibility of the public health sector. To find out more about this, we're going back to Dr. Robalo, who is also a former Minister of Health of Guinea-Bissau.
A public health expert really has not only the opportunity, but the space and the influence to promote access to sexual and reproductive health services for young girls and for women, and contribute to the policies and implementation of interventions, delivery of interventions that will prevent maternal mortality. Unfortunately, it is not a direct effect that we observe in these areas, because there are many factors that influence access to services, and there are many factors that influence impact on the outcomes for women and young girls. These factors are essentially related to the fact that access to quality services in the health sector depend a lot on other sectors of government. And many times, more often than not, it is difficult to have the other sectors of government really involved in the delivery or in adopting policies that will improve delivery of essential health services. What I mean by this is, for example, improving infrastructure, roads, bridges, etc., have an impact on how quickly, how soon, how easy pregnant women can access hospitals, maternity wards, or even health centers for their reproductive health checks and prenatal care services, or when they are about to deliver their children. And many women, one of the third delays that are very well recognized is that the delay in getting to the health facilities are responsible for high maternal mortality rates. So this is a component that lies outside of the health sector and have an impact on what the public health decision maker can do. But definitely, when you have a significant role in the public health sphere, there is a lot you can do to improve access to sexual reproductive health services, to maternal and child health services, and beyond that, because access to quality health services, as you know, go beyond these two areas, and we need to be having also an approach that looks into the health of women throughout the lifespan, not only during their reproductive health, during the reproductive age, but we need to look at the health of women throughout a life, because there are many factors, risk factors, and conditions that actually impact on their ability to live healthy lives.
The Conference on Public Health in Africa, which will take place in November, will bring together health leaders from all over Africa to talk about a range of public health issues, including how to enhance healthcare access for young girls and women. We turn again to Dr. Mofokeng, who will be leading the conference's debates on access to healthcare for women and girls in Africa. To learn more about what can be done to increase women and girls' access to healthcare.
This sounds like it's so simple, but it really is so simple. We have to make sure that we have functioning, effective primary healthcare systems. These are the healthcare systems and facilities that are closest to where people are, that are closest to where people need them. And there's a particular importance of embarking on a policy approach to public health, because a policy approach to public health brings across multi-stakeholders around the table to take on important decisions around resourcing, prioritization, and making sure that we truly do not leave people behind. It's very important, as you think about a policy approach to primary healthcare, that the amount of facilities available must be adequate in number, and they must be able to have adequate healthcare professionals, as well as adequate equipment and medicines, which are some of the top complaints that patients experience in terms of long waiting times. They don't have medication, they have to pay out of pocket for services. But with a human rights-based policy approach, one of the very first things that we would need to target and improve is availability of adequate facilities that are functioning and effective. The other important element is of accessible both physically and economically. You have many people with disabilities, with many other limitations and restrictions, who are not able to access the facilities. Sometimes you have discrimination as an element that leads to inaccessibility, because communities are from a particular ethnic group, they are from a particular indigenous population, or they may even be from a migrant or refugee population, and because of discrimination, they are unable to access services. We know many LGBTIQA plus persons who also need maternity, sexual and reproductive health care are also unable to access health facilities because of political, cultural, and legal influences on themselves. And so we need to address discriminatory laws and policies and practices and inequalities that affect the ability of the system to provide quality service. So I would say for me, focus on primary health, good resourcing, getting enough healthcare workers, and making sure that we deal with the issue of discrimination in healthcare systems is really, really important. And of course, when it comes to the issues of underlying determinants of health, you want people to have literacy. You want them to be able to understand and participate and provide things like informed consent. You want them to have roads that are safe for them to go from their homes to the clinic to seek care even outside of operating hours. So it's a whole system approach that is required, but it does need resourcing and really clear leadership in terms of political will.
You have been advocating for universal health access. Do you feel this would assist improve the provision of reproductive health services for women and young girls?
I think it's important as a focus because, in a perfect world, we wouldn't need to be advocating so hard for these rights because they are recognized in international human rights law. They are recognized in international human rights standards. They are recognized in consensus documents and statements, both internationally and in many regions of the world. And so for me, I advocate for equality. I advocate for a human rights-based approach, for dignified care ultimately, and for people's autonomy to be respected. But on the one hand, I always talk to policymakers and leaders and hold them accountable for the failures that they are exhibiting in terms of poor planning, poor understanding of the different contexts and intersectionalities around sexual and reproductive health rights. I mean, just one example is how many children in many countries are continuing to be raped. And yet in the media, when it gets reported, it's reported as teenage pregnancy. We are now laying blame on young women for getting pregnant and having evidence of a rape or sexual assault. And yet we are still not naming the root cause, and we are not naming the power dynamics that are happening and the brutality of what rape is, right? So these are some of the things that I'm advocating for, because how you name particular things and how you frame them gives them a particular meaning, and that can make itself into a policy. And those policies then get resourced in a particular way because of our framing and understanding. And so I think some of the things that we want to change for a more gender equal world, to a world that's free of violence, where young women and girls can thrive, we have to pay attention to sexual and reproductive health rights. We have to pay attention in how we continuously, talk about them as if they're inherently vulnerable and disempowered, and not really naming the important issues that go in terms of what disempowers young women, what obstacles do they face in terms of their sexual and reproductive health rights, in terms of their right to grow up in safe communities as well. And so for me, it's a holistic advocacy issue that highlights a lot of what, firstly, is wrong that many people experience in terms of control of their sexuality and their reproduction, but also gives us that hope of what can go right when we embark together behind a vision of protecting and promoting human rights for all.
Now, we go back to Dr. Robalo to explain how stigmatizing sexual and reproductive health services might prevent access.
This is a very common feature in across societies in Africa, where young girls don't have free access to sexual and reproductive interventions such as contraceptives for them to prevent falling pregnant at a very early age. Because girls who would come to a health facility for let's say a consultation on sexual and reproductive health and request for contraceptives will be seen as a girl who is not well educated, and those services are bad to them. That's why, unfortunately, we end up having a very high prevalence of abortion in very dangerous conditions, which leads to mortality of those young girls. There are laws in many countries that prevent young girls as early as 14, 15 years of accessing contraceptive methods for preventing them falling pregnant. And this is a problem that we encounter in our health facilities. There have been attempts to create safe space where young girls can go and speak to trained health workers who can talk to them, understand their circumstances, and educate them on how they should prevent themselves from falling pregnant, and provide them with the interventions they need. But very few countries actually have these programs who are run successfully. The stigma from society, the pressure that older adults, older people exercise on young girls still have a lot of influence in those services and prevent them from implementing very well-designed programs. You also see stigma in the area of HIV, for example. If a woman tests positive for HIV, there is stigma associated to that. She finds it difficult to disclose a status toward to a husband or to a partner because she fears being considered the one who is guilty of having acquired the HIV infection. And if a man is found to be HIV positive, very often you'll see the woman being condemned, being accused of being the one responsible for passing on the disease to the husband. So there are several types of stigma around the health of women that prevents them from speaking freely about their condition and seeking care and help from health workers when actually they could be treated much earlier, they could be helped much earlier and prevent a negative outcome from the condition they are having at a particular moment. This is also something that we need to continue working with our health professionals, our community health workers, our nurses, our midwives, our doctors, to educate them about the particular needs that women have, and very often find it difficult to communicate, to disclose their situation for fear of being stigmatized, for fear of having their family members and the community looking negatively at them, and the impact that can have. They can be rejected by the family, by the husband. They lose some of the financial or even resources such as land, for example.
One of these sexual and reproductive health services is access to safe abortion. Without access to safe care, these procedures can be dangerous and even fatal. But with education and access, women can be empowered to make the choice that is best for them and their families. We turn again to Dr. Mofokeng.
I think it's important when we're talking about the limitations around, access to safe abortion. And sometimes the limitations are one of illegality or where they have criminalized abortion. So there's a penalty in some law somewhere that restricts abortion access. And we need to deal with that, because whether or not a country decides to make an abortion illegal or criminalized, it doesn't mean that abortions are going to stop being the reality of people's lives. Some abortions are spontaneous, some abortions are induced, and either way, the abortion has to be safe. And we need to make sure that the people who are seeking information firstly have information. And in the context of criminalization or some illegality, it's very hard to be open and to provide credible, good information, because that opens up a layer of people who are in the black market, who are pill sellers, and they're just pretending, and they're fake healthcare workers running fake clinics who are taking advantage of this state that people are in, where they need to make a decision to have an abortion. So for me, it's very much to advocate for safe abortion and to remove all penalties in laws that seek to criminalize or punish people for seeking abortion. It's also important to remember that when we are talking about abortion, we are talking about a pregnant person and a fetus. And often the language and the framing of that discussion already gives some emotional expectation, or what I call emotional blackmail, where we're already talking about fetuses as if they are babies or children. They are not yet. A fetus is a growing, physiological state of pregnancy, and we need to also just check that the language and the cultural and what we have accepted as norms are really not norms. They are just really perpetuated by the idea that women should not be controlling of their sexuality and their reproduction. And remember, in colonial times, the controlling of Black women's fertility was part of what the violence of colonizers used, right? When it came to many issues of not eugenics, not just population control, but also who gets to give birth in what dignity and the conditions in which that happens. So we need to respect the right of people to make these decisions unconditionally, but we also need to make sure that those decisions are made with services and trained healthcare workers, and that they have information to know where to go and by when to go. The thing about an abortion is that it's timeless, right? There are specific times in which you need to present to have a safe abortion. And so we know many women go on to have another pregnancy, which they feel that, yes, I can keep this pregnancy to term, and I'm in a position where I'm empowered enough to be able to do this. And they do that. They carry their pregnancy to term, and they're fine, and they give birth to their babies, you know? So even the story about abortion care, I think it will help with stigma, is to tell the complete story, that it doesn't just end with someone wanting an abortion being done. Many people who are married, many people who want children, still make the decision ultimately, with everything considered, to still go for an abortion. So an abortion is not something for women who are irresponsible, young, or just only if your life is in danger. Abortions are something that are part of our daily life as people who get pregnant. And there are many reasons why many people find that their pregnancy is unsupportable. But equally, you have patients who've had an abortion, who had very successful and good experiences, and want to keep their second pregnancy or their third or fourth or fifth pregnancy. And they too deserve to be able to have pregnancy care without that stigma that once upon a time they had an abortion.
That's all from us at Science Explained today. If you want to find out more, head to the SciDevNet website. That's www.scidev.net. Today's show was produced by Alice Hurst, with editing by Titi Lope Fadari and Ogechie Kianyao, and hosting by me, Ogechie Kianyao. Today's reporter was Michael Kaloki. Until next time, goodbye. Africa Science Focus is produced by SciDevNet and distributed in association with your local radio station.